Hi, everyone. My name is Rachel at JBS International. I do want to welcome everyone to this webinar. Just a few reminders. We do ask that you keep your lines on mute. That way we'll be able to hear the presentation. So please go ahead and take a second to mute your line unless you are given the ball to speak. Also, just please note that this webinar is being recorded. So if you have any issues with that, you may want to disconnect now. Other than that, I'm going to go ahead and turn it over to Phil with Children and Families Futures.
Great. Thank you, Rachel. And welcome, everyone, to our first peer-to-peer webinar of 2018. We hope to have at least 2 of these. We also will have an opportunity for in-person clinical training in August that we will update you on later. Before we get started, again, if you could please mute your line when you're not speaking, that would be really helpful. But we would like to start with a roll call. And so we will start with our 2017 grantees, and then we will move forward to our 2015 grantees. So kind of I'll go in alphabetical order. Okay, first one is the 4th District of Nevada, Elko. So if you are on, unmute your line, please, and then just announce who you are and who's with you. If you have multiple attendees, that would be very helpful. So anyone from the 4th District of Nevada?
Yes, this is Mary Pitts, and it's just me.
Great. Welcome.
Thank you.
How about anyone again from Clark County, Washington?
This is Pierce County, and we just signed on.
Okay, great. Thanks.
We're doing the roll call. We're starting with roll call.
Oh,
how about
sorry.
County of Erie, New York? Okay. County of Santa Clara, California?
Hey, good morning. This is Brittany Hilbig from Santa Clara County.
Brittany, thanks for joining. All right, and how about Dunklin? Oh, Julia's here from Dunklin County. Julia, anyone with you?
Yes, Lisa's here with me.
Great, welcome. And how about Fort Peck? On the line from Fort Peck, Montana? Okay. How about Georgia?
Chatham County, Savannah, Georgia, Latrell Galata.
Debbie Montgomery Sullivan from Hall County.
Great.
Janicia Harper, Criminal Justice Coordinating Council.
Welcome. As many of you might have noticed, Georgia is a multi-site grant. How about Hillsborough County, Florida? Okay. And Humboldt County. Anyone from Humboldt County? Okay, thank you. Montgomery County, Ohio?
Oh, this is Treasurer Lucita from Montgomery County. I have with me Kyla Woods, who is our program coordinator. Also, we have a couple of treatment providers and I believe children's services that are on the line. I'll let them introduce themselves here in just a second. And our magistrate, Nicole.
See if I can actually talk at the computer. I'm hoping I can.
Should be on here momentarily. She had a trial.
Thanks for joining.
Thanks.
Hi, this is Heather Stevens and Amita Pajaro. We're calling from South Community. We're the treatment provider associated with the Montgomery County Family Treatment Court.
All right, and we have Judge Rowley from Tompkins County. Anyone else joining with you today, Judge?
No, I'm by myself.
Okay, thanks for joining. And then how about from Oklahoma?
This is Kelly Earls. I'm the project director for Oklahoma County, and we have our coordinator, and I believe both of our treatment providers are on as well.
It's good to talk with you, Kelly. Thanks. Okay, Pierce County, I think we heard from, and how about Tarrant County?
We have John Haynes. I'm the project, the principal investigator on the grant, and we have Suzanne Lofton, who is our drug court coordinator, and Jennifer Gilley, who's our executive director for Challenge.
Okay. All right. And Van Buren County, Michigan?
Rachel Lindley, project director.
Hi, Rachel. Thank you. And how about Iowa?
This is Kathy Thompson, and Beth Moore is also on the line, who's our grant coordinator.
Thanks. Hi, Kathy. Hi, Kathy. Hi, Beth. And last but not least of the 27 grantees is Milwaukee.
Hi, yes, Sue Clark, project director, just me.
Okay, hi. Okay, now we're going to go to 2015 grantees. I apologize, this is taking a minute. Is there anyone from Harris County? Okay, how about Illinois, Cook County? Charles County?
Juliana Davis, project director for Charles County Family Recovery Court.
Welcome.
And Helen Harrington, the FRC judge from Charles County.
Hi, Judge.
How are you?
Good, thanks. Okay, and I think we may have already heard from Okmulgee in Oklahoma. Kelly, guys.
Yeah, and we have the treatment provider and coordinator are on as well.
How about Pasco County?
And this is Michelle Artabile, the project director for Pasco County, and also we have treatment provider representation from Pasco County, and we also have all of our Pinellas team on the line, even though they're not SAMHSA grantees.
Okay, great. Yeah, welcome. And Marion County, Indiana.
Hi, I'm Laura Schilling. I'm the project director.
Hi, Laura. Great. And then we heard from Alameda County. Gavin, you're on the phone. Anyone with you?
No, I'm the project director, and it's just me today.
Great. Thanks, Gavin. How about King County, Washington?
This is Jill Murphy, and we have our treatment specialists with us, April Wilson and Kathy Lehman.
Jill, everyone. Pima County. And let's see. I did Charles County. Who did I miss?
I just want to double check to make sure you got Pierce County, Washington.
Yes, we did. Thank you.
Thank you.
Did we get Travis County, Texas?
Yes. Oh, maybe did I skip Travis?
Yes.
Okay. Yeah, Travis County. And I missed Austin.
We're able to get Franklin County, Massachusetts. Sure.
Okay. Yeah. Oh, that's right. I was going to come back to you guys. Yeah. Thank you for joining.
You're welcome.
Okay. All right. I think that's everyone that's here. If you are just joining the call and you weren't part of the roll call, but you are on the call, you can use the chat function, I think, in the WebEx and send us a note letting us know you're here. And I think, actually, Rachel, you may want to take the ball back so that we can show Amy's slides.
Sure, I'll do that now. Thank you, Phil.
Okay. So while you're doing that, I will just introduce you to, well, first I'll welcome everyone again. And my name is Phil Breitenbuscher. I'm with Children and Family Futures. I'm the Director of Family Drug Court Programs here, and it's my pleasure now to introduce you to most of your project officer, Amy Romero, and I know she's joined also in her office with John Berg. So Amy, I'll turn it over to you now.
Thank you, Phil. Good afternoon, everyone. Actually, John was unable to join today, but he will be listening to the recording a little bit later. He had a meeting, so I will be the only one from SAMHSA here today. I would like to welcome all of our grantees, but before I start, I would like to ask everyone to please mute your lines. It will make the process of the webinar a lot easier for the speakers. Please mute all of your lines. Thank you. So welcome everyone. This is our first, as Bill said, our first Family Drug Court peer-to-peer webinar. These webinars have shown to be very successful with our cohort funded in 2015. They're now on their third year of funding, and I really hope that our first-year grantees can find these to be very helpful as well. This is a great opportunity to network and learn what other grantees are doing, how they are implementing best practices, lessons learned, and barriers that they had to overcome. Usually during these webinars, I provide with some SAMHSA updates, and we have 2 grantees that present on a topic. I hear some back noise. Can everybody hear me okay?
Yes.
Okay.
Yep.
Okay, today's topic is therapeutic responses to the opioid crisis and utilizing medication-assisted treatment in family drug courts. Next slide, please. Well, I wanted to share a map of our geographic distribution of all of our 31 family treatment drug courts. We're very excited that this year we have 31 programs, and you can see if there are other programs funded in your region. We encourage grantees to collaborate with one another. You are doing the work on the ground, day to day, and you're the experts in the family treatment drug court field. Please collaborate with each other. If you need to find contact information for someone, for another program near to your site, let me know, and John and I can provide that information. Next slide, please. Please check your GIPRA data. Please ensure that that data is accurate, especially for 2017 grantees. Ensure that your target numbers are accurate. After the first year of funding, it is a little bit hard to change those numbers. Let us know if those numbers are accurate. And also for those of you that are in your third year, keep tracking those numbers and let me know if there are issues or concerns with your target numbers. We don't have cohort GIPRA data for our 2017 grantees yet. Some of you have started entering data just a few weeks ago. But by now, all of our grantees should be serving clients and entering data into the SPARS system. So all of you should be serving clients. And you have up to 7 days to enter GIPRA interview data into the SPARS system. We really would like you to do it as soon as possible, no later than 7 days between the interview and the time when you enter that interview in the SPARS system. Our goal is to be able to see accurate data. And if you're not serving clients yet, please contact your government project officer as soon as possible and let us know what challenges are you having with that. On this slide, I included the SPARS help desk information. In case you have any questions about GIPRA, you can always contact the SPARS help desk. And here you see our average GIPRA rates for our 2015 family treatment drug courts. As I said, we don't have enough data for our 2017 cohort, but our intake rate for our 2015 family treatment drug courts is 85.45%, and follow-up is 62.63%. These are cohort rates. And as you can see, this is an improvement from our last call, so I think we're doing better. But I encourage all of you to continue trying to improve that follow-up rate. For every intake, we should have a follow-up interview. That is the only way we can compare intake data to the interview data, to the follow-up data. Otherwise, we don't really know if your program is making an impact. We have to have a follow-up.
Hello.
Next slide, please. Here we see client demographics for our 2015 cohort. So most of our programs are serving female clients at 66.9%. The age, most of our programs are serving clients between 25 to 34 years old. Most programs are serving, in the race category, you see mostly white, 56.1%. Black or African American is 20.9%. And then we have other rates right there. And then for ethnicity, we have an 18.6% Hispanic and 81% non-Hispanic, and that is for, I think it's a wide category. All grantees should review your disparity impact statement. That is part of your grant application that was submitted 60 days after you submitted your grant application. So I recommend that you look at your disparity impact statement and compare that information to your client demographics. Also, look at the child welfare data that you have at the local level and compare that information to your population. We would like to ensure that you are meeting all the requirements of the disparity impact statement and you're servicing the population that was stated on your grant application. Next slide, please. Continuation applications have been received for all grantees and are in process of review. For 2015 grantees, carryovers are in process of review. If you have a carryover under 10% of your yearly budget, that is automatically approved. If you have a carryover between 11% to 25%, you will receive approval or disapproval by next Friday. You will know by next Friday, April 27th. If your carryover is over 25% of your budget, approval will take a little longer. You will hear if it was approved maybe in mid to late May. Also, biannual reports are due on April 30th. That is the deadline. April 30th for biannual reports. I think one or two of you submit quarterly reports. Please check with JBS on the deadline for the quarterly reports. Most of you should submit biannual reports. And then I just have an announcement regarding the data summary template. And I don't want to confuse grantees, but starting with our 2015 grantees, you have been submitting the data summary template at the end of the second year of your grant, and you have one more due at the end of your third year. That is no longer a requirement, but you are required to submit data on family functioning and children outcomes. You can choose to continue submitting the data summary template for your last year of funding, or you can submit that data in any format that you would like to submit it, but it has to be part of your yearly evaluation report. So the template is not a requirement, but the data it is. You have to submit that data to us at the end of year 3. For new grantees, the 2017 grantees, I did share during the grantee meeting a little bit about the template of the data summary template. That is not a requirement for you. We no longer have the resources to provide any type of training for that. So you just have to follow the FOA. So it is a requirement that you provide us with family functioning and children outcomes. You can choose to do it in your own format as part of your yearly evaluation, and you have to submit that at the end of the year. Please review your funding opportunity announcement, pages 14 and 15. Okay, so now I would like to take questions. I think there may be some questions about these items.
Amy, can we just chime in?
Yes.
Okay. For FY15 grantees, when would the no-cost extension, is there going to be any mention of that for continuing funds after September 29th of this year?
Yes, you can submit a request for a no-cost extension 60 days before the end of your grant. So sometime around July, and I can send an email to all of the 2015 grantees with some guidance on how you do that, and that is on the SAMHSA website. But I can just get that information from the SAMHSA website and send it via email. And you have to submit your request for no-cost extension 60 days before the end of your grant.
Okay, can you send that following the webinar today, Amy?
Yes.
All right, thank you so much.
Okay, questions about the data summary template? for 2015 grantees. So I would really encourage 2015 grantees to keep on submitting the data summary template as you have, just because you have been doing it for a long time now. If it's, and I think it may work better for your program as part of your evaluation, but again, it is not a requirement, and you can choose to submit the data in a different format. Okay, questions for the 2017 grantees regarding data submission. Okay, and we will be sending an email with instructions on how to submit that information, pretty much the same thing that I just communicated, but it will come via email from your GPO, and we will include a copy of the funding opportunity announcement so you can see and review pages 14 and 15 to see what is actually required. Okay, next slide, please. Okay, and I just wanted to bring up some of the training opportunity announcements that we have. JBS will be hosting 2 trainings on trauma. One is gender-specific for females. The other one is gender-specific for males, and you could see the dates on the screen. Also, we will be having a training for family drug courts on evidence-based practices on August 7th to the 8th. I really encourage all of you to attend and participate in that training. And you can have also staff that haven't been in previous trainings or are not able to attend NADCP or other training opportunities. This is going to be a very good training opportunities on the family drug court model. And you can also participate at the NADCP conference that it's a schedule from May 30th to June 2nd. We will not be having a SAMHSA grantee meeting, but we will be having a family treatment drug court track when NADCP will be having the family treatment drug court track as they have every year. Okay, and that's all I have. I think next slide, if I could take questions regarding training. Okay. Thank you, and I will turn it over to Phil.
Thank you very much, Rachel. I'm sorry, Amy. And again, thanks, Rachel and JBS for hosting this webinar. Again, this is Phil Breitenbuscher with Children and Family Futures. And I think we know most of you very well. Some of you are just now getting to know, but JBS has contracted with us to provide technical assistance and training with you through the support of SAMHSA. I wanted to make sure everyone on the phone was aware that in March of 2017, as a field, we released the first ever National Strategic Plan for Family Treatment Courts. That plan laid out 3 major goals. One was to ensure the quality of family treatment courts. The second was to expand the reach of family treatment courts. And the third was to improve the research and the knowledge of family treatment courts. And as SAMHSA grantees, all of you are contributing to that strategic plan in many different ways, and we appreciate your efforts. As of February 2018, we were able to identify 495 family treatment courts currently operating in the United States. This is a tremendous growth from 2012 when we were able to only identify a little over 300. So we've seen a huge expansion of treatment courts, especially in the last few years with the opioid epidemic on the rise. I also wanted to make sure that all of you were aware of a couple other programs that are available to you. One is the Peer Learning Court program that's supported by the Office of Juvenile Justice and Delinquency Prevention. These are 8 courts that were selected across the country who are performing best practices in alignment with best practices, and they've volunteered to share their materials and to participate on phone calls with you and even host site visits if you're interested in attending one of these courts. If you're interested in learning more about the Peer Learning Court program, you can contact us after the webinar. I also wanted to make sure you were all aware that as a field, we're developing family drug court best practice standards, which will be released to the field in fall of 2018. So we're very excited about that. And as Amy noted, at the National Drug Court Conference in May and June, we will be hosting a Children and Families track, our Children and Families program, which includes at least 18 sessions. And that combines the family drug court track. So there's lots of training available to all of you at the national training, so we hope that you're able to send teams. Today's webinar, which is titled Therapeutic Responses to the Opioid Crisis and Utilizing Medication-Assisted Treatment in Family Treatment Courts, is an important topic as we hear just about every day on the news of the opioid crisis that's happening across our country. And unfortunately, the new term that we've come to know here at Children and Family Futures, in some states where we're the term opioid orphans. And we know that you're on the front line battling this epidemic, and there's concerns about how do you effectively engage parents in your family treatment court so that you can, first of all, keep them alive, but secondly, treat them and help them move into recovery. And so we're very happy today to have two of your peers, the Honorable Judge Rowley from Tompkins County Family Treatment Court join us, and also Julie Spillman from Dunklin County Family Treatment Court, Missouri. These two courts, in addition to being your peers, are also national peer learning court or mentor courts. So we're excited to have them, and I am now going to introduce to you Judge Rowley, who will talk about his experiences in Tompkins. Judge?
Yeah, thanks, Phil. I'm going to go ahead and cut mine down to 12 and see if we can leave time for questions. Good afternoon, or if you're in an afternoon part of the country. Tompkins County is in upstate New York. We have about 100,000 population, one large city. If you look at our next slide, you can see what we are dealing with here in Tompkins County. Now, I think what's most interesting, our old slide didn't make it in. We had 5 years ago only 35 parents in our program, and only 4% of those were using IV heroin. 5 years later, you can see on our snapshot, 77 parents, 61% have a history of IV heroin use. If you're not experiencing this level, then you pray that you never will. But most of us, I think, are or will. And this reality really has caused a fundamental shift in our how we reach out to parents, how we think about the disease model, and how we implement our program itself. So that's what my focus is going to be today, is some of the ways this has impacted us, the changes we've had to make, and the new understandings we've had to come to. I've included here just an idea with this medicated assisted treatment model, which is now, of course, being utilized across the country to different degrees. We have very little access to methadone. Vivitrol, which many people are excited about, and I know some of you may or may not be totally understanding all of the different medications, but it's still not a very popular drug among our parents. Suboxone is our main medication assistance treatment, and that's the one that I think in general the opioid disorder users are going to be seeking. Next slide, please. So I think the most important thing about opioid use that I had to wrap my mind around, and I think that all of us have to think about, is, what is driving this behavior? So when you have new parents coming in, as we did a few weeks ago, and we're removing their children, and they're saying basically, that's not even top on their mind. They're like, yeah, the kids are out of here, but we need help. We need help right now. And of course, we do not yet have help right now available to them. But really, what are they experiencing? What is that desperation coming from, and why is our response so important? And why does it not work when you say we'll come back tomorrow? If you don't fully appreciate what these folks are going through, you really need to come to understand this from the medical model. I think the American Society of Addiction Medicine has a lot of good information out there, but one part of their definition of this addiction, they say that the behavior is reflected in an individual pathologically pursuing reward and or relief by substance use and other behaviors. Bottom line is that if you talk to opioid use disorder folks, they are desperate not to. So if you talk to a person who is experiencing this, they say, I'm so looking forward to getting high tomorrow, but that I can't go through withdrawal. It's 10 times worse than going through the flu, and it takes 3 days, or it's 100 times worse. So I just think it changes the way we respond when we understand how deep the need is on a both psychological, but even more importantly, on a physical level. So faced with this need, so let me try to be succinct here, get us to some of our important points here, that each community has to deal with access to your medicated assistance treatment. We had a lot of different barriers. You undoubtedly will too. Moving fully into this approach definitely changes the protocols. And we were not even testing for Suboxone in our regular drug testing. Now we test for Suboxone, first of all, to make sure that people prescribed Suboxone are taking Suboxone, and also looking at people who are seeking it out, who are not prescribed it but are taking it, diverting it. I think the most important things that I want to talk about, though, is the next point, and then going on to our engagement practices. That this is not substituting one drug for another, and there seems to be a lot of bottom line here, is that we have to have a much more therapeutic approach with this particular population. There is so much shame in this behavior. IV drug use, I think, is crossing a line that is of great concern for people. We know that many of our women are dealing with transactional sex, where they're engaging in shameful behavior that they don't want to talk about. It takes a real effort to bridge and to have them feel safe enough to let us know what's actually going on. When we go ahead and respond to them in a punishing manner, we lose them before we even engage them. I thought a good analogy would be like the diabetic who's waiting in their office to get their insulin, and then the doctor refused to treat them because they're eating a donut. We've got to really push ourselves on this issue of compliance, non-compliance, life-saving. Because if we get medicated assistance treatment in place for a person, they have the ability then to access treatment and to then begin to get better. But until we get over that initial barrier, they're really lost to us because they're lost to themselves. Next slide, please. So let me just we don't use a jail sanction for parents at all. It's been our practice from the beginning. It really goes to the integrity of our program. We have a very high rate of parents saying yes to the offer of help, and I don't think that would be the same if we were threatening them, if we were taking people out in handcuffs. I appreciate that the reality that people may die. If you have somebody in front of you who is asking for help, you can't give them a detox bed, but instead remand them to jail. I think it's an abuse of the process. This is a civil court that we're dealing with. It's certainly counter to any of our engagement efforts. And I think that you could think of other situations where we don't respond that way. I mean, a suicidal person, we call an ambulance and send them to the hospital. If we don't have the right hospitals for the needs of our people, we need to advocate for more medical treatment for them. But I'm opposed to using jail for that purpose. Next slide, please. We do use warrants, though, under the circumstances described here. I think what's important about this is our engagement committee. We have, and this was through Children and Family Futures guidance and assistance, where we created a committee that looks at, that gathers together all the people that may be intersecting with individual parent. Because when you look at it more closely, people who are not coming to court are sometimes still going to visitation. Sometimes they're even going to treatment. Sometimes they're having ongoing contact with their parent's attorney. So we gather all those folks together and try to come up with a strategy of how we can engage that person And we've had some success with it, very targeted engagement. Certainly peer supports are an important piece there, and we're just adding that component to our new SAMHSA grant. So we're looking forward to hopefully reporting more success with that. But then our next step is to require them to attend a day reporting program if they're not otherwise engaged. We're lucky enough to have a reporting program, day reporting program that's focused solely on treatment and employment, education, mental health, those kinds of things. So it's really not punitive. In fact, we require any person coming out of inpatient treatment, anybody who's unsuccessfully discharged from any treatment program goes to our day reporting program until they have stabilized, make sure we have safe housing, get them engaged in treatment again. We do issue a warrant if all of that fails, and we have, I then remand people door to door. So they get sent to the jail, and we have good, fast access to inpatient treatment, and we get people moved to inpatient treatment in a expeditious, at least as expeditious as possible. You know how it goes, sometimes different times of the year, et cetera. Next slide, please. So this is our outcome rates. We have really turned around our focus in the last number of years from our concern about the potential risk and what might happen to dealing with the reality of a chronic relapsing disease. We're looking at the big picture more than we are looking at the narrow details, so that we are looking at things like safe housing, who people are associating with, what are they doing for using community resources, how have they done in treatment, and we're not then getting a positive drug test and pulling kids or disrupting a return plan. We're dealing with those as part of this relapsing disease, and you know, it can keep you up at night, but I think that we've got much greater engagement. We keep adding more evidence-based programming, child and parent psychotherapy, strengthening families. Those kinds of programs I think are doing better for us to feel like our parents are more competent, more able to keep their kids safe, rather than us sitting around worrying about whether they're relapsing or what's going to happen next, because there really is a safety net that didn't used to exist. So let me stop there. I don't know if we're going to end up having time for questions, but that's those are my thoughts.
Thank you very much, Judge. Appreciate that and appreciate your patience in sticking with us. Okay, we're going to, hopefully Rachel or someone at JBS, can you unmute Julie Spillman? Julie Spillman is the Treatment Court Administrator at Dunklin County Family Treatment Court in Kennett, Missouri, also a peer learning court. Julie, if you're unmuted, we welcome you to the webinar.
Dunklin County's situation is a little bit different than Tompkins County. Heroin hasn't reached our area yet like it has other parts of the country, but we do have a large number of participants using prescription opiates or alcohol. So most of our MAT in Dunklin County is being used for prescription and alcohol use. However, we have had many of the same challenges in implementing MAT. Next slide, please. We first started hearing about Hi, did we lose Julia? Hello?
Yeah, it looks like we did. Julia, if you're speaking, we can hear you.
We're still here. I can hear you. Hello?
Yes. Julia, are you on the line?
Yes.
Okay, go ahead.
Yes, okay, so I can hear you guys all the time. It just seems like I must cut out. So I'm not sure where it cut off, but
we would come back from treatment and talk to our providers about the possibilities of MAT, but the main concern was the expense of the various medications. Providers and other team members worried about the cost of the medications and how they would be covered. Would we be able to distribute it fairly to everybody, or would it just be people who were covered with Medicaid or insurance that would be able to use it? And then there were also concerns from team members that this was just substituting one substance for another. Next slide, please. We addressed the expense concerns first. We met with our Vivitrol rep for our area. She was familiar with all of the funding available to assist providers in acquiring MAT for participants, not just the medication itself, but also the medical and psychosocial services that go along with it. We met with the rep and our treatment provider, and she walked us through the funding available through the state and how the providers could access reimbursements. At that time, funds were available through Missouri's Department of Mental Health. Next slide. Next, we addressed the other challenges such as acceptance of MAT by all team members, doctor availability, and getting the treatment court counselors on board with screening for MAT eligibility up front instead of waiting until the participant was struggling and then trying it as a last resort. The court wanted it to be an option from the first day of assessment because of the training we had received, but it was new and not always considered early in the treatment plan. Training and education of team members was important to promote understanding and acceptance of MAT. Cures Act funds have been used in Missouri to start a shift towards evidence-based models, MAT models, instead of abstinence only. The Department of Mental Health has been working with primary care providers and treatment centers throughout the state to accomplish this, which benefits the treatment courts as well. MAT education and training has assisted the team members and treatment providers in getting on board with MAT in our treatment court. Some of that training has been through the providers themselves, some has been through treatment court conferences, and then I'm sure there's many websites available that you can share with your providers if they need training. In 2017, appropriations were approved by the Missouri General Assembly, established funding for medication-assisted treatment. And the wording was, it was for the purpose of funding treatment programs focused on medication-assisted treatment for Missourians with substance use disorders related to alcohol and opiate addiction. It stated that the Drug Courts Coordinating Commission shall enter into agreements with the drug courts, DWI courts, veterans courts, and other treatment courts of the state in order to fund medication-assisted treatment programs. When this funding became available last summer, we immediately applied for it. There have been some challenges to accessing the funds, just on the practical side, but I think this is typical of any new funding source. It takes time to work out the details and understand the requirements that go along with the money. And even though this funding is specific to Missouri treatment courts, I think it's a good example in general of the challenges that arise in accessing funding. And I think our solutions to these challenges can be applied to funding sources in other states as well. The funding is available for us to cover medication, medical services, and psychosocial services, but it has to be billed through the treatment provider contracted with the Office of State Courts Administrator. So the challenges included how the treatment provider would bill us for lab services at the local hospital, the doctor visits, or prescriptions through the pharmacy, as we could not pay those agencies directly. We met with our provider and created a separate funding track for the MAT clients, a process for billing the outside services through the treatment provider, and a referral protocol. So it takes coordination between the counselors, the court, and the provider's billing department to make it all work. Our treatment provider had to be willing to contract and work with some outside agencies on our behalf to make this work. Our participants are now also screened for MAT appropriateness at the assessment and go immediately into that track if agreeable. The provider works directly with a doctor that is available for our participants, and a protocol is in place to get them started on MAT within a few weeks of assessment. So our lessons learned from our implementation of MAT, which hopefully can apply to other areas as well, are talk to your team members about MAT and find out if all are in agreement with using it. If they're not supportive of MAT, explore the reasons why and then offer trainings on those issues. find out what funds are available in your jurisdiction for MAT, identify the state agency or any agency overseeing the funds. For us, it was the Department of Mental Health and then the Drug Courts Coordinating Commission, who oversees all of our drug court funding in Missouri. And then find the right contact person, become familiar with the requirements and procedures to access the funds, and then meet with your provider and develop a plan for MAT around those requirements and procedures. So then our next topic was jail as a sanction. Our team decided as early as the planning initiative trainings that we would not use jail as a sanction in family treatment court, and we never have. We did explore different ideas during the discussions, such as only taking cases that were accompanied with a criminal child endangerment charge so that we could use jail as a sanction. But in the end, all practitioners agreed that sanctions are not used for participants in the juvenile court system, so they should not be used in family treatment court either. We're a parallel court, and the juvenile court judge, as well as the attorneys on the team, are all supportive of this decision. But that doesn't mean that team members don't sometimes get frustrated with that. It definitely makes responses to negative behavior more difficult than it is in adult criminal treatment court. Responses have to be more creative. It's a lot easier to just threaten jail time for negative behaviors. So we do our best to change behavior through setting achievable goals that are met with rewards instead. We have a reward system that the participants track themselves. They're given a log or a tracking sheet in court each week. When they attend treatment or a drug test or court or any program event, they get a signature. The next week in court, they trade those signatures in for tokens. They can then use those tokens to purchase items at the treatment center, such as snacks, hygiene items, notebooks, pens, or they can make a one-time payment on their program fees. So this rewards them for the simple act of showing up for treatment in court, and then more tokens are given for bigger accomplishments like getting a job or getting back in school, things like that. And then in general, our program's whole milestone approach is based on setting achievable goals, which are then rewarded by progress through the program, increased visits, changes in visitation status, and eventual reunification and closing of the case. So on the other side, therapeutic or treatment responses to negative behaviors also have to be imposed. Increased counseling, additional treatment curriculum, attendance at alumni meetings for extra support, and increased testing are all responses that we typically use. They are, however, presented not as a sanction, but as a response to behavior that should be therapeutic and not punitive in nature. And next slide, please. And then those are our outcomes since 2008. We've been operating longer than that, but 2008 is when our state started collecting the data. So our graduation rate is at 64%, and we usually stay around 25 to 30 participants. And I guess that's it.
Thank you, Julie. This is Phil again. Any questions? There's a chat box feature, and we did have a question that was submitted to us. It was to Judge Rowley, and I'll just go ahead and read that out, Judge, in case you're not able to see that one. What's involved in the day reporting program? How often is that offered for program participants?
We have a 5-day-a-week center that folks arrive at 8:45 and they're excused by 1:30. They have a regular schedule of classes during the day. It varies every day. But given all the other demands on parents in family treatment court, they're released to go to any appointment. They're verified for treatment, but they can go to mental health. They can go to their substance abuse treatment. They can even go to 12-step meetings and return.
Great. Thank you. And there's a couple other questions. And again, the best way to ask a question would probably be to use the chat function. And you can just submit those to us. We'll monitor that. Back to you. How about maybe for Julia or Judge, did any of your team members express any type of unique concerns or challenges while implementing these programmatic changes? And how did you work through those?
Julie, anything special with your folks? I think ours was pretty straightforward.
Ours too, really, other than with the MAT, just making sure everybody was trained and understood, you know, some of the basics that you went through in your presentation about why we needed to use it in the first place. But I think everybody was fairly well on board with ours from the beginning.
And Judge, you mentioned that you are monitoring the MAT. Did you have to make any changes to your staffing forms?
Yes, absolutely. I mean, when you go from 0 to being in the middle of this, I mean, it didn't even exist. It didn't even exist in our minds. We had no knowledge of it. So, I mean, the first thing I can recall is when we're getting our drug testing results, and all of a sudden they're starting to star that it's positive for Suboxone. It's like, oh, positive for Suboxone. That's a good thing. Well, it's a good thing if they're prescribed Suboxone. In fact, I would now argue it's a good thing either way. But back then, we were very concerned about whether you were prescribed it or not. And so all of our reporting forms had to change. Our understanding had to change. And like I said, just to add on to that, you know, previously, I'd be quite nervous about people buying Suboxone on the street. The whole issue of diversion is a big concern, but really in the end where I'm at with that is that diversion reflects mostly a lack of an adequate supply of a necessary drug, and as we start to increase the supply, the diversion will become less and less of a problem. But just in case you're not in that mindset, people are buying Suboxone to have in case they can't get heroin so they can bridge between this use and next. So just a whole different way of thinking about this.
Yeah. Julie, anything to add to that?
No, I would say that we have changed our staffing notes just to make sure our counselors do let us know at admission that they've referred them for MAT, and then we monitor it and make sure that they're still in compliance with it as we go.
Great. And last question, because I see we're over time. As you mentioned, your providers, how is the communication between your providers and your program and your prescribing physicians? If your providers see that maybe the dosage isn't right for a particular parent, how have you bridged that communication?
The whole prescribing of Suboxone is a long and tortured story, but primarily it started for us where physicians, doctors within the treatment agencies were the prescribers. We actually are just starting to get into some family doctors who are prescribing, but this has mostly been internal. So and that's generally been handled well by our treatment agencies, I would say.
That's actually the exact same for us. So far, it's been doctors within the agency that we've worked with, so the communication has been great. But we are starting to see some private family practitioners in the area starting to do that. So we actually have talked about meeting with them and just kind of making sure we're all on the same page when we have participants that are going to see them. But that's new for us as well.
Great. Well, thank you both again, both Julie and Judge Rowley. We appreciate the time you spent to put these slides together, put your thoughts together. And I want to thank all the participants as well. Thanks for sticking with us through the technical difficulties. I'm sure we'll have those resolved by the next webinar. Last two items or questions that came in are one, someone asked if this PowerPoint would be available to you, and the answer is yes. And the recording link will also come out to you from ABS. And we will also be sending out to you the announcement for the training in August very soon. So you should be receiving a save the date for this August training in the next week or so. With that, I will just want to, again, say thanks to everyone. You see my email address there. If that's really hard to spell, you can just do FDC, like Family Drug Court, FDC@cffutures.org. And we would be happy to respond to any questions you might have. With that, thanks again to everyone. And Amy, if you have anything else?
No, thank you, everyone.
Okay. And with that, I think we will conclude today's webinar. Thanks for joining.